Hello, this is Amir, Hematology Registrar. Welcome back in the Hematology Bleeps. Our today's topic is resuming anticoagulation in a patient who is on regular anticoagulant drug but admitted to the hospital with a bleed. So during bleed, we have to interrupt the anticoagulation, but the usual question from medical or surgical team to hematology registrar or consultant is that when should we start anticoagulation again in this patient after the bleeding episode? Unfortunately, there are no guidelines, no formal guidelines to give a reference from that. All the recommendations regarding resumption of anticoagulant medication in a bleeding patient depends on or derived from practical experiences. So the two common bleeding episodes are either intracranial hemorrhage or GI bleed. People use anticoagulant medications, warfarin, Duox, dabigatran, etc., or lomotil heparin for different indications, and they are on these medications for a long time. For example, someone has atrial fibrillation and high Chartwell score, so he will be on Duox or warfarin, and he will be using these medications for years and years. Someone has hereditary thrombophilia, antithrombin deficiency, for example, and his history of VTE, DVT, or PE. So these patients will be on long-term, lifelong anticoagulation. So when these patients are admitted with intracranial hemorrhage or admitted with GI bleed or any sort of bleeding, then we have to interrupt the anticoagulation. We cannot treat their bleeding episode and give anticoagulant drug at the same time. So, for example, if you have a patient of antithrombin deficiency, for example, and patient is obese as well, has a family history of VTE, personal history of VTE, he was using rivaroxaban, and then he had melena or GI bleed. Now you have to stop the anticoagulation. If he was taking rivaroxaban, you have to stop it. If he was taking warfarin, you have to stop the warfarin in this patient. So then you have to scope the patient to find out what is the cause, from where this bleeding was coming. Sometimes the patient will have any gastric varices or Gave disease, the gastric and antral vascular ectasia, or duodenitis, or problem in the ileum, etc., jejunum, etc., maybe different causes of GI bleed. Okay. So then you have to stop the anticoagulant in this patient, and you have to address the bleeding first. Then, once the bleeding is addressed, once the bleeding source is addressed by OGD or by the gastroenterology team or by the other team, then we can think about resuming anticoagulation in this patient. So the general principle is that you have to find out whether this patient is at high risk of thrombosis or at low risk of thrombosis. So normal recommendation is to resume anticoagulation in GI bleed patient after 2 weeks. But if someone is very obese, bedbound, uh, and has antithrombin deficiency and previous history of VTE, previous family history of VTE, then I would be worried. Then I should resume the anticoagulation after 7 days of GI bleed. Um, but the problem is that you have to address the bleeding first. Even after 7 days, if he is bleeding, I cannot introduce the anticoagulation in him. I have to stop the bleeding within these 7 days. So if you have addressed the bleeding and within few days of presentation and patient has stopped bleeding, then you can resume anticoagulation after 7 days. But that resumption of anticoagulation will be a graded resumption. You will start with lomotil heparin prophylaxis for a few days, and once you are sure that the patient is acting good there is no complication with prophylactic dose, then you can convert to therapeutic dose of lumekrivit heparin. Because this patient has previous history of bleeding, recent history of bleeding, I mean, better to split the dose of therapeutic lumekrivit heparin into two. For example, if a patient is requiring 26,000 units of lumekrivit heparin, divide it into two, 13 morning, 13 evening. And once you are sure that this patient is okay on therapeutic doses of lumekrivit heparin, he does not bleed, he didn't bleed within a week, then convert that to either Duoc or warfarin, depending upon your consultation with the hematology team. Likewise, if someone is admitted with intracranial hemorrhage, for example, and he was on Duocs for atrial fibrillation, for example, then in intracranial hemorrhage, we usually avoid anticoagulation for 4 weeks and resume it after 4 weeks. Some people would say 3 weeks, but majority would resume the anticoagulation after 4 weeks. And that resumption will be graded one as well. You will start lumekrivit heparin first, prophylactic dose for a few days. If patient is uh, tolerating the prophylactic dose, then convert to therapeutic dose of lumekrivit heparin. If patient is tolerating it, then convert to the tablet form, Duox or warfarin, whatever you like. But discuss with the hematology team or review the indication of Duox or warfarin if you are a hematologist. But in those patients who have uh, high Chadwa score or high risk of thrombosis, then in that case you can give this patient lumekrivit heparin prophylaxis after 2 weeks or after 3 weeks and give it for a few days, and then convert that into lumekrivit heparin therapeutic dose. Better to give it in split form and then convert to either warfarin or Duox. Okay, so the basic takeaway from this talk is that in GI bleed, you resume anticoagulation after 2 weeks in a graded fashion. Means first few days lumekrivit heparin prophylaxis, then lumekrivit heparin therapeutic dose, and then tablet form. But if there is a high risk of thrombosis, then you resume anticoagulation after a week. Again, in graded fashion, first introduce lumekrivit heparin prophylaxis for a few days, then therapeutic lumekrivit heparin for a few days, and then convert to tablet form. Then, likewise, in intracranial hemorrhage, restart anticoagulation after 4 weeks, but start first with prophylactic lumekrivit heparin prophylaxis for a few days, then convert to therapeutic dose of lumekrivit heparin, and then convert to tablet form, Duox or warfarin. But if the risk of thrombosis is high, you can reintroduce the anticoagulation after 2 weeks if there is no concern with bleeding and no concern of bleeding on re-imaging of the brain as well. But that reintroduction should be graded one as well. Lumekrivit heparin prophylaxis first, then therapeutic dose, and then tablet forms, warfarin or Duox. If there is any other site of bleeding other than the intracranial hemorrhage or the gastrointestinal bleeding, follow the same rule. If low risk, after 2 weeks. If high risk, after 1 week. Start with lumekrivit heparin prophylaxis for a few days, then lumekrivit heparin therapeutic dose, and then tablet form. So this was a talk regarding the resumption of anticoagulation in a bleeding patient who were using anticoagulants for any indication. I'm sure this will be a bit tough for non-hematology colleagues. Better to discuss with your hematology registrar or consultant in your hospital. And this video is equally good for the hematology registrar or consultants as well. Thank you very much. See you next time. Take care.